We know, all of us, that the recent guidelines by the European Society of Vascular Surgery and Society of Vascular Surgery recommend the routine patching against routine primary closure. But in our lecture, we're against extreme. We are saying that selective patching in the carotid endarterectomy, but not routine patching, is the best, and we have a systematic approach. Despite the up-to-date guidelines, the Society of Vascular Surgery and the European Society of Vascular Surgery recommend routine patching in the carotid endarterectomy over routine primary closure, but there is still a debate between surgeons in the routine, selective, or primary closure. What is the rationale beyond these guidelines? The rationale that routine patching was associated with significant reduction in the preoperative ipsilateral stroke and the reduction in the 30 days ICA thrombosis. And those patients exposed to the carotid endarterectomy with primary closure are more prone 3 times to return again to the operative theater within 30 days. On the expense of the long-term outcome, routine patching also associated with significant reduction in the late ipsilateral stroke and in stroke, and the most significant difference between the routine patching and the primary closure, that restenosis, the late restenosis with patching is 4.3%, and with the primary closure is 13.8%. And this really a great statistical difference between primary closure and patching. But when we reviewed systematic review article that has been used mainly to produce this results of the guidelines of the European Society or Society of Vascular Surgery, we can clearly see the criticism in the content and discussion of the systematic review article itself. They said that, however, the results of the randomized controlled trials might not be completely reliable. Why? Because of small size, lack of true intention to treat analysis, and significant losses to follow up. Another criticism to the studies that the conclusion, it's undesirable, it is in higher, maybe higher in the primary closure. It's not always associated with stroke. And the recurrent stenosis is statistically significant, has significant difference between the primary closure and routine patching in the favor of routine patching, but we need to notify that the restenosis or recurrent stenosis after carotid endarterectomy is markedly different from the primary stenosis. Primary stenosis is atherosclerosis, while the recurrent stenosis is hyperplasia and is very rare to cause embolization, and is very rare. It's mostly innocent and associated with a lower risk of neurological symptoms than in the primary stenosis because of different pathology. The other question here is routine patching the major cause for ipsilateral stroke or cerebral ischemia in the carotid endarterectomy? You can say clearly no. The study published in the Society of Vascular Surgery 2008 studied the factors associated with the stroke or death after carotid endarterectomy in the northern New England. They stated that the factors as following: age more than 70 years, contralateral ICA occlusion and antiplatelet agent use and congestive heart failure, emergency procedure or pre-op ipsilateral cortical symptoms. And no one spoke about the patching of primary closure. And this study published in Society of Vascular Surgery and International Society for Cardiovascular Surgery in 1998 studied the incidence, timing, and the causes of cerebral ischemia during carotid endarterectomy with regional anesthesia. All factors increase the interoperative ischemia. One of two major factors, with increased the degree of the stenosis, ipsilateral stenosis, increase the degree of cerebral ischemia, and increase and with contralateral occlusion and contralateral stenosis, higher contralateral stenosis is also associated with increased the chance of the cerebral interoperative cerebral ischemia. And you have a question: is one of these factors related to routine patching or primary closure? Till now, nothing. In this study, published in the Journal of Vascular and Endovascular Surgery 2015, they studied the mechanism of the procedural stroke following carotid endarterectomy or carotid artery stenting. The results show the following: that hemodynamic and technical difficulties are the most important factor associated with procedural stroke. Hemodynamics like hypertension, hypotension, arrhythmia, severe bradycardia, and the technical difficulties is very important. And we have a question: is patching associated with more difficult technicality or primary closure? I'm sure that patching associated with higher technical difficulty. With patching, in spite of all studies said that there's no difference between type of patch, but all of us know the patch has a rough surface and soft surface, or a non-rough surface, and any fallacies in the application of the correct side associated with high thrombogenicity. The patch itself associated with technical difficulty more than primary closure because it is more liable, need more experience, need more time, and maybe there is mismatch with increase or decrease the size of patch. So this thing is in the favor of primary closure, not patching. This study published in 2016 proved that increased duration of the operating time for the carotid endarterectomy associated with increased mortality and the return to the OR and increase the length of the stay. And we have a question: patching in the carotid endarterectomy has longer time or a primary closure? I'm sure that patching has a longer time. The same thing is, they spoke about the effect of different risk factors on the cerebral ischemia, and they stated that longer clamping time associated with higher chance of cerebral ischemia, and the longer clamping time sure with patching, not with the primary closure. Study published in 2010 in the Korean Surgery Journal, comparing between outcome between primary closure and patch angioplasty in the carotid endarterectomy. They said that primary closure following carotid endarterectomy is not necessarily inferior to the patch angioplasty for experienced surgeon. So this means the volume of surgeries and volume of surgeries in the surgeon and in the institute is more important than patching or primary closure. In spite of this study, they proved that there is higher rate of recurrent stenosis after primary closure in comparison to patching, but all of us know that recurrent stenosis is hyperplasia, different pathology from primary stenosis, that's atherosclerosis, and so the recurrent stenosis usually is innocent and not associated with cerebral embolization. And in this study, they proved that technique and the more fine technique, better results. And I think that the primary closure gives you a higher chance to refine your procedure than patching. What's our home message? First of all, we have many criticism against these European guidelines and Society of Vascular Surgery guidelines, and we need to rethink again in these statements. First, they depend on one systematic review to gather data. This is not enough. Second, the 10 randomized trials used in this systematic review that has been used to gather the data is not enough. 10 randomized trials with this small number of cases over 10 years' time is not enough to gather a reproducible evidence. Third, the difference of rate of ipsilateral stenosis and ICU occlusion is still around 4% or lower. In the clinical practice guidelines, it is significant, but not greatly significant as in the restenosis rate. Most of the studies published focusing on the risk factors, as we mentioned before, did not speak about the patching, but they mentioned other risk factors like contralateral occlusion, contralateral severe stenosis, ipsilateral severe stenosis, technical difficulty, longer time operation, hemodynamic instability, and less fine procedure. And nobody spoke about the patching or primary closure. Still, duration and technical difficulties are major risk factors for the ipsilateral stroke and cerebral ischemia, and that could be worse with routine patching, not the primary closure. With routine patching, longer time. With routine patching, the chance for technical difficulties and fallacies is higher, and error is higher because of need more longer time, more liable to artery kink, mismatch, longer patch, shorter patch, and fallacies in the selection of the surface. Need more experience in the primary closure. And we need also to study the patching alone was fixing all other variables. We need to study the patching alone as a factor, fixing all other variables in the procedure to take a clear decision. Head-to-head studies between routine patching and selective patching is not available. All is available between routine patching and routine primary closure. Thank you so much for all our audience. I hope that I added a clear criticism to our important guidelines in the European Society of Vascular Surgery and Society of Vascular Surgery. Thank you so much.